Hello, everyone. Good morning, good afternoon. It is a privilege for me to meet you all here through the, proudful EduFest by my own office, the Divisions of Plastic Surgery and Reconstructive and Aesthetic Surgery of FKUE and also RSJM. I have no disclosure with this sharing. I would start, I will start with the data that I took from last year event, which the audience are mostly GP and it was about 60%. And for those who also GP who have the practice of more than 5 years is about 11%. Interestingly, we also got 6% of the participants who are specialists, which is we are very grateful for that. And also some of them were students and interns. When I ask about cases of hand trauma, did the participants see most? We can see from this data that they saw skin laceration and tendon rupture as the most cases, and also followed by balance in between fingertip injury and hand fracture and dislocations. Some of them mentions about amputations or crush injury, and also a small amount with human or animal bite. So, responding to the questions, how do you think dealing with cases of hand trauma? It sounded like, it's not that easy for doctors to deal with hand trauma. Some of the data shows that, it's hard to understand because the complex structure. Well, I would say, from the very beginning, when you are now joining us with discussions about hand trauma, I would say, you need to embrace the concept that there is nothing difficult. If you have the interest, everything is going to be easy. So I'm going to share about the basics to deal with hand trauma, which I do really hope that, it's going to be helpful for you in having the structure of the concept dealing with the cases. This is an example of a young man fell from a motorbike while sitting at a rear seat, and the bike ran at 60 kilometers per hour. Now you could see from the picture that the lacerations or the wound existed in the dorsum of the ring and the middle finger. One side is in the DIP joint in the ring finger, and also another one is just near the PIP joint of the middle finger. Now, you could consider what would be the structures that may be injured through this case. So, it may not be related only to the skin injury, but also deeper structures. Now, if you want to recall yourself, what are the structures at the dorsum part of the fingers? Yes, definitely you are correct. Then we could see that the dorsum of the fingers under the skin was covered by complex extensor structure or extensor system, or we can simply call it extensor tendon. The main cable for the fingers at the dorsum would be the extensor longus or extensor digitorum communis. Of course, there are also structure because it's basically like a blanket. The extensor system, I admit, it's a bit tricky to understand, but let's make it simple. Now you could understand beside the tendon, the system of the extensor tendon, then you may deal with the deeper structures at this, dorsum part. What are they? Of course, the bone and also the joints. Depends on the level of the trauma. It may involve only the joint, but also, sorry, it may involve only the bone, but also it may be involved with the joint. Other soft tissue structures may not be that important, but then, venous structures at the dorsum are the structure that you may consider. The volar side may have different, orientations about, structures of the fingers. So at the very basic, now you understand that you need to know the anatomy and the functions and what underlying structures may involve, like I have, discussed it with you. Then after recalling the anatomy, which I believe, you can, mimic yourself that, your own normal hand are the normal anatomy that you could refer. So when you refer into the anatomy, look into your own hand, then it's going to be easy for you to, start to simulate the anatomy, the knowledge of the anatomy, and then, relate it to the functions. So what about the movement? With it specific attentions on which part that some structures or particular structure move a certain particular bone or joint. Of course, if I call about movement, it should be referring to the joint, not the bone. The bone is the site for the tendon to attach with, where, when the tendon pull, then the joint would move. Then the next point that you need to recall is about the sensory functions. It's very easy because you can recall the dermatome of the radial, median, and ulnar nerve. It's very easy. You can just Google the anatomy about the sensoric territory. And of course, when you need to, make your diagnosis, and then, you suspected that the bone or bony framework, including with the joint structures, were involved or are involved, then you may need supporting X-ray. Okay, so beside the data that we have discussed, we also need to recall the understanding about the mechanism of injury. Although you do not need to be too elaborative, but knowing the concept of the mechanism of injury, you may see one of the important or simple information is about the low velocity or high velocity in related to the mechanism of injury. Back to the case. Now you could see from the volar side, you see that the injured finger looks to be involving the volar side in the ring finger, but then more obvious if you see the dorsum part. Now, the picture in the middle, behind me, then you could see when I ask the patients to extend all the fingers, including also the thumb, then you could see all the fingers could extend. Of course, the fifth finger or the digiti minimi, we could not see it, but then I could inform you that it did not suffer from any injury. So at the basic, the two involved digit, I mean the two digit that involved with the trauma could extend. Now what do you conclude? Then you could recall that most probably the extensor tendon are in good function. But then how come that the ring finger could not extend fully like that? That may be because of pain, and of course deeper structures may be involved. So then, if you agree with me, then you may need X-ray to make sure that you are actually suspecting deeper structure, in this case bone and also joint. So what about the function itself? Now you could check whether the patient still flex the DIP joint. When it still be able to be flexed, then you could recall the joint may not be really involved, but pain could be an obstacle for you to check. Now from the X-ray, you could see that the patient suffered from fracture of the middle phalanx. It's in the neck of the middle phalanx, like you could see in the photo. Now you could refer to the photo from the AP here, okay, and also the other photo from the oblique positions. Of course, this is clearer that the neck of the middle phalanx is fractured. Okay, so I move to the second case. This is a labor worker, suffered from wound at the dorsum part of the thumb. So the level of the wound is in the proximal phalanx level, and it is at the dorsum. Now, I jump from fingers now to the thumb. Okay, so the extensor system may be simpler compared to the extensor system of the fingers. Now, you could just recall that the extensor system in the thumb comprise of the long extensor for the thumb and also short extensor for the thumb, meaning that the long extensor is the EPL, extensor pollicis longus, and also the thumb has extensor pollicis brevis, the EPL and the EPB. So when you recall the EPL, where it inserts, now you understand that the EPL, main extensor of the thumb, inserts in the distal phalanx, the proximal part of the distal phalanx. Now, if you ask the patient to extend, then the IP joint of the thumb would extend. If the injury is in the level of middle phalanx, now you could see most probably the EPL could be lacerated. It's different with the EPB, where the EPB has its insertions in the proximal phalanx, that it might not be involved. So you could see that, the picture was taken from a video where it shows that the patient was not able to extend the IP joint. So thumb only has one IP, so we do not have, we do not have PIP and DIP for the thumb. Now you could see, you can suspect that the EPL may be ruptured rather than only the skin lacerations, and also, of course, with the venous injury at the dorsum. Now, you could see the difference from the picture on your right, okay? Now, you could see, on your right here, compared to the normal hands on the right, when I ask the patients to extend both of the thumb, now you could see that it is obvious the left thumb could not be extended. And from the photo, the static photo here, now you see the difference. The thumb, although I asked the patients to extend, it's still in flexion positions. So most probably that the EPL is ruptured. Now you could refer to the surgeon for the repair. Now let me bring you into the volar side of the fingers after understanding the example of the dorsum of the fingers and also the thumb. Now to the fingers. Fingers is a bit tricky, but let's make it simple. The finger flexors are basically only two, the FDS and the FDP. Now you could see the FDS, as following the name, it's flexor digitorum superficialis. So its position is superficial to the FDP. FDP is deeper than the FDS. However, now recall into the positions of insertion, site of insertions of the FDS. The FDS insert in the base of middle phalanx, while the FDP inserts in the base of distal phalanx. How come that the FDP is positioned deeper but then insert into the distal phalanx, which is, distal, more distal than the insertions of the FDS? So then, this is the explanations where the FDS tendon starts from the MP joint level is actually splitted. So it split and form camber of chiasm. Now, here the camber of chiasm, the hole that is made by the deficiency of the FDS to allow the FDP to go in, to go through. So after splitting, forming the chiasm of camber, then it's winds the FDS into 90 degree. So then the FDS goes further and insert into the distal phalanx. Now, if I ask you who's actually responsible for the movement of the of the DIP, then the FDP. And FDS is responsible for the flexions of the PIP. That's very easy, right? Okay, now let's go into this video. Now you could recall on the functions that may relate to the potential anatomical structures that is injured. No, so I ask the patients into flexing the ring finger. Now you could see whether it is flexing. Yes, the patients could flex the PIP. Now, once again, you could see an example on the ring finger, whether the patients could flex the PIP. It flexed. So where's the point of the DIP flexion then? So DIP flexions would be different in terms of checking it. So this maneuver is to check the functions of the FDS to flex the PIP. So there is a bit different with the index, where you could see the index with flexions of the PIP along with the DIP. Now, the other maneuver is to fixate other fingers to allow a particular fingers that you are checking to flex. So those are the examinations for the FDS functions, flexions of the PIP. So how to check the functions of the DIP is very easy. You just restrain both of the proximal and middle phalanx and then ask the patients to flex. Then you may simply check the functions of the DIP or functions of the FDP. All right? So that's very easy. Okay, hopefully that you could understand. Now, with this case, recalling the anatomy and knowing the functions, now you understand the lesions, the lacerations is actually taking the proximal phalangeal level at the volar side. Now it's very obvious, right? The patient fell while stepping down stair steps, and then left hand accidentally grabbed a dish rack with sharp edge. So it comes with with these conditions, with this picture. So now you could understand that there is skin lacerations with potential soft tissue injury, including the nerve and also the blood vessels. So you need to check on how the vascularizations of the pulp. When the vascularization of the pulp is in disturbance, meaning that it's disturbed, it cannot be, like normal, then you could suspect there is lacerations with the artery. And so with the sensations, you could check with the modality, simple modality to just, apply the light sensations, whether the patient could sense it, then you could suspect the nerve injury. Now back to the important structures with the movement structures, the tendon. What's the tendon may be ruptured in this part? Back into the anatomy, then you could suspect both of the tendon may be ruptured. So then you could check on how to check the FDP and the FDS. I have already explained it. So it's very easy for you. So do not be afraid dealing with the case of trauma in the hand. Now, if I ask the patients to flex like this without restraining other fingers, it's very obvious that the patients may be able to flex the PIP, but then the DIP is not moving. So then you need to check it, confirm it. Now you can check it whether the DIP is in functions. Now you can have the clue, right, that the FDP is ruptured. All right. So obviously the case involved with the skin problem, meaning that, by the injury, it's also losses of the perforator. So then part of the skin flap, which is made by injury accidentally, is actually in jeopardy. Okay, so the next case, back into the thumb. Now it's in a bit on the volar side. It's also simple that the thumb has main or long flexor, and also has the shorter flexor. So long flexor is, yes, flexor pollicis longus, and also it has flexor pollicis brevis, which is basically an intrinsic tendon. So the flexor pollicis longus insert in the distal phalanx, okay, and then the flexor pollicis brevis insert in the proximal phalanx. Now the positions of the laceration is in the joint level. Now you could suspect which part of the structures that may be injured, and it's still radially, okay. So the radial cable with the artery and nerve may also be injured. So then you can just, check it to confirm whether your hypothesis is correct or not. So with this part, we could see also that the bone is involved. Like in the picture, you see, yes, correct. So, here, the fracture on the thumb, sorry, that. Okay. Okay, so now you could check with the motion. So now I bring you into the fingertip injury, as I have shown you the slide about the cases that you deal in your daily work. This is about fingertip injury. So what to do with this fingertip injury? It's basically like amputations, The pulp of the fingers actually avulsed. Now you could consider on how to manage it. One of the very easy to manage it is just to put it as composite graft. So the composite graft is not easy to be expected to survive. It may be survived in a very young baby, baby in the neonates age or period, or less than 3 months old, that has the potential to be successful with this composite graft. But with this case, basically the composite graft is shrink, and then the patient healed by secondary intentions. So then one of the complications for fingertip injury is hook nail deformity, like the picture you see here on your right. Okay, so recalling the anatomy, you need to understand that the nail could grow nicely because it has normal nail bed with proper distal phalanx. The distal phalangeal bone is very important to be a stable platform for the nail to grow. So if the patient's got, fracture or deformity with the distal phalangeal bone, then the nail would be involved. So Recalling into the tissue reconstructions, surgeons need to consider to reconstruct the pulp, the nail, and also the bone. Okay, so this is an example again to bring you into the further detail of the anatomy related to the fingertip injury, where there are some classifications of fingertip injury, but you could recall into the Allen classifications. So we could see the Allen type 1 on your left, going further there. So the level is basically only on the fingertip, beyond the nail bed. Okay, so just distal to the nail bed. It involves only the most distal point of the palm of the finger. So what about the Allen type 2? Now you could refer to the next line, the Allen type 2, distal half of the nail bed without loss of the distal phalangeal bone, meaning that by radiological photo or by palpations or by inspection, you could recall that the injury of the Allen 2 does not involve the phalangeal bone. Phalangeal bone is intact. So what about the Allen type 3 or zone 3? Now you could see it involves the proximal half of the nail bed and of course with the loss of the distal phalanx. The Allen type 4 or zone 4 would involve more proximal. Like this, it involved the proximal to the lunula and also involving the dorsal vein often available. Okay, so here you could see some example on the way surgeons reconstructing the finger using flap. Basically, they are advancement flap with a V to become Y shape as the product or the outcome of the surgery, and that could be from the volar side or from the lateral side or radio-ulnar side, with two flaps to meet together in the axis of the finger or the digit. The other example on how surgeon reconstructing fingertip injury is using cross finger flap. This is just an example where the finger is attached to the neighboring finger for 3 weeks, 2 to 3 weeks, and then the surgeons would divide them. Okay, so what's the done for you as doctor dealing with fingertip injury? Do not just creating pouch sutures, making like closing a pouch, just just stitch it to make the wound closer together, and that could be improper. And of course, the other point is not to ligate the artery. So you just need to stop the bleeding gently by pressing or by a bit of compressions, bandage. That could also help the surgeons to deal with the reconstructions later on. And which part of the Allen classification for you to be able to manage yourself? Of course, the Allen type 1, because it's going to be simple. With the proper diagnosis of Allen type 1, you can heal the fingers by secondary healing. So just change the dressing properly and it will heal by itself. Of course, putting the patients under the splint would be good for you to provide comfort. Here are some data on the complications of fingertip injury. Then one of the aesthetic related complications is about the nail deformity, which is very good for you to understand. It's not just a real or simple cases if you do not have proper understanding dealing with fingertip injury. The other cases that you need to discuss with you or with your peers or with your consultant is about hand burn. I'm not going to talk about hand burn, but it needs very very empathetic attentions because of the potential deformity like you see in this case, very severe deformity with the hyperextensions of the MP joint. So I would give you an advice which is very simple. Dealing with the potential hand injury and burn that may need quite long time to heal, just put the MP joint on flexions. If it is possible, put the IP joint in extension. So this position is called as position of safety, just to save the MP joint to function well when it comes into the chance for the patients to have rehabilitations. Okay, so the next case that I would like also to discuss a bit is about amputation, which I believe all of you has already understood on how to deal with the amputated part. So the very basic informations for you is just to clean up the amputated part and then wrap it in a clean gauze and then put it into dry container, which is very easy to use the plastic wrapper like this, and then put the first container into the second container, which contains water and ice cubes, just to make sure that, when it travels, the amputated part travels in a cold ischemic time rather than, let it go into the warm ischemic time. That would decrease the chance for success in the replantation surgery. Okay, so I do really hope then, at the next occasions, you could learn further about, actions to do debridement. Maybe a workshop on basic hand injury would involve the pneumatic and mechanical tourniquet, and it is good for you to understand the chemical tourniquet. It contains epinephrine or adrenaline, which is no longer seen as dangerous for fingers, including penis as well. Okay, so maybe in the future you could deal with your workshop on suturing and also what do you call splinting, and also stitches. Of course, sutures and stitches are also the same. And then about hand dressing and also splinting would be good for you to understand. So the last point that I would like to share it with you is about the message that hand injury needs rehabilitation, which is not only a task of surgeon to deal with the hand problems, but also doctors in rehabilitations or physiotherapists to help us with the rehabilitations. This is an example where in the past we used this kind of modality, but now you could just discuss it with the team in the rehabilitations to make sure that you got proper attentions with the rehabilitation phase for the patients. Once again, before I end these sessions, is just to remind you that MP joint is a very important joint for fingers, and put it in flexions anytime you can predict that you need, long term of immobilizations needed to heal the problems, the wound of the patients. With that, I would like to thank for your kind attentions. I do really hope that I got the chance for you to deal with Q&A. And of course, I'm not here with you leaving this recording because I'm not here. I'm now in other country to share the experiences with plastic surgery. Thank you very much and see you later.